Hello, everyone. You're welcome once again to the Early Intervention Matters podcast. We're really happy to have you here. This is a podcast that's dedicated to transforming the way we understand, identify, and support children's development from the earliest moments. And I'm Dr. Inyang Takon. I'm a consultant neurodevelopmental pediatrician. I practice in the UK and have done so for over 2 decades. So this is a platform. We have clinicians, researchers, families, young people with lived experience. They come together because every voice matters and when it comes to supporting children. And we built something really rich here with one episode after the other, going deeply into the matters that really affect children. So today I'm so pleased to have Dr. Nadler with us, and he's going to talk a lot more about himself. He's going to tell us about his work and introduce himself. But I was so pleased to meet Dr. Nadler on the Podmatch platform. And one of the things that made me very keen on his work and his profile was he seemed very passionate about one of the main issues that I do see with the community of children I see, and that is obesity. In the UK, it's a growing problem. It's really growing problem, which we haven't been able to get a handle on. We still struggle with pathways to be able to get help for the children. And families have been stuck in this wheel of diet, exercise, and sometimes families really feel isolated and feel frustrated because the amount of work they're putting into getting results, it doesn't show up and they get stuck because the professionals time after time look at them to say what's really going on with your child. So I was so pleased to read all some of the work that Dr. Nadler has done. So thank you so much, even for coming over to joining us on the
No,
podcast today.
it's my pleasure, and thanks for reaching out to me, and thanks for inviting me, and thanks for having me. Super important topic. Childhood obesity in general is a global issue. Used to be mostly a U.S. issue, but now it's all over the world, including countries you wouldn't even necessarily think of having
Yeah.
obesity problems. And they're especially important, as you just mentioned, in the children with neurodevelopmental differences. And those families, I'm sure, in the UK are similar to the ones in the US. They really struggle to find resources. They struggle to find people who understand their situation, who are willing to tackle it head on. And I don't profess to have all the answers, but I can definitely share some that I've learned over the last couple decades. And I guess to introduce myself, people should know that I'm a pediatric surgeon and have devoted the better part of 2 decades, or actually, I guess I finished my training in 2004. So whatever that is, 22 years to childhood obesity, and specifically in the early days, bariatric surgery for children with obesity. Although now I've done a lot more in the pharmacotherapy or medication prescription for children with obesity, and have a special place in my heart for the children with neurodevelopmental differences. Again, because the families struggle so much. All the families struggle, but these families generally struggle a bit more because in large part there are folks who are just a little bit reluctant to provide the same care for obesity to children with neurodevelopmental differences, even though that's really what we should do, is treat everyone exactly the same. But we'll get more into that, I'm sure, as the
Yes, we will. Yes. And you're right. When people are making care plans and planning management plans, it's almost like a different take when it comes to how far they go with children with neurodevelopmental
I can tell you
differences.
I'll start with an anecdote that people might find interesting. And as I'm sure your listeners will come to understand, I'm a little bit of I don't know if I want to say instigator, but I stir the pot a little bit. I do things that I think are right, whether or not other folks may think they're right. And so early in my pediatric bariatric surgical practice, there was a patient who came to me with Down syndrome. And she was actually a young adult. But in the US, the adults with Down syndrome or autism spectrum disorder, the adult surgeons won't take care of them. So they came to me, and the family had custody and all the paperwork, et cetera. And they wanted bariatric surgery for their child because I can't remember, maybe the mom had bariatric surgery or maybe the dad or both. And they knew it could help their child. She had bad sleep apnea, diabetes, those things that come with obesity. And this was, again, early in my surgical practice. And so I decided that because it was somewhat outside of the typical unethical patient, then I'd bring it to the ethics committee. I'd have the ethics board discuss whether a patient with Down syndrome was an appropriate candidate for bariatric surgery. Because in the old days, and maybe still now, there's this hurdle that the patient must be able to understand and adhere to the postoperative dietary plan.
Mm.
And some patients with Down syndrome are very high functioning, can do that, and some aren't. So I brought it to the ethics committee. And to make a long story short, the ethics committee came back to me 50-50 split. So the chair of the ethics committee sat me down and said, half the people on the committee thought it was okay for this woman to have surgery, and half the committee did not. So in the end, it's a medical decision that you have to make. And a light bulb went off above my head. And I was like, yes, it's always a medical decision. There's nothing ethical, unethical about it. It's a medical decision. And if I think that this could help the patient and the family agrees, then I should do the surgery. And if we don't, then we shouldn't. And in fact, I flip it now on the ethics committee type people, and they say, I would argue that it's unethical not to offer it to someone because of. So anyway, that was like 15 years ago or some long time ago, but there are still many pediatric surgeons in the US who feel that ethics committee input is important in certain cases. And it probably is in certain cases. But truly, it was like the epiphany moment where I was like, I don't need to ask the ethics committee for permission to what's medically appropriate. If the family is in agreement, it just has to be medically appropriate. So anyway, I didn't mean to take up too much time with my stories, but.
No, but that's a really good point you've raised, because I think medicine as a whole, sometimes if we're not careful, we become stuck on the letters rather than actually looking at the patient and the child in front of us.
I think the Hippocratic Oath, which all doctors take, which is first do no harm, a lot of people interpret that as don't try something new. But in the case of childhood obesity, not intervening actually does harm, right? We know what happens to these children over time. So again, I sort of flip the Hippocratic Oath and tell people, listen, you're doing harm by not referring the patient or not trying a medication or not doing something that's within your medical degree and comfort. It's not baby fat that people are going to grow out of. It's actually a disease that is going to get worse with time.
Yeah. And I think that's the thing that a lot of people need to think about, that what's the long-term impact of not doing something. And thank you for taking that angle as well, to hear somebody actually putting the child at the center is great.
Well, you said that I'm passionate. You got from my work online that I'm passionate about childhood obesity. That word might be a slight understatement. I might be obsessed with it or something more than just passionate about it, because I think about it all the time.
It's good obsession. Yeah. So can you tell them, why did you decide to specialize in obesity?
Right.
Childhood obesity.
Yeah. Nobody, or at least not 20, actually I did my first bariatric surgery on a child in 2004. So nobody 22 years ago went into pediatric surgery to take care of obesity or take care of children with obesity or 300, 400 pound or 150 kilo teenagers. We go into it to take care of little babies with congenital disorders, and because we think of the babies as the most vulnerable patients. And I was actually at a meeting, a pediatric surgery meeting, presenting data that was from my time in the research lab that I was working in. And so I was still a trainee at this time. And I was actually at a pool in the Disney resorts in Florida in the US. And I looked around the pool, and, most of the people at the pool were struggling with their weight. And there was a boy across the pool from me who particularly caught my eye because he was about 12. And he clearly had a weight issue, and he had like a 2-liter bottle of Coke, a 1-pound bag of potato chips, or crisps, as you would say in the UK, and a greasy hamburger. And I leaned over to my wife and I said, somebody in this country has to do something about the obesity problem, and especially in children. And that sort of started me on the path. And at that time, naively, I kind of thought it really just meant educating the world about the perils of childhood obesity, and that changing the diet of children would be all that we needed. Because again, this was in like 2001 or something, so 25 years ago. Since that time, I've learned there are a lot of biological drivers. There's genetics and epigenetics, and even the brain telling the child to eat food that they choose is probably part of the disease and not a willpower issue. It's not that the child or family thinks that those are healthy options. They may either not have the economic means to have other options, or again, I believe there's some degree of biological drive to seek out these hyper palatable foods, the salty,
Mm.
sugary foods, and that it wasn't going to just be as simple as, changing food back to the way it was in the 1950s or 60s or whatever. It was going to take a bigger lift. And so that's sort of where I am now, which is trying to, like, those things are important. Don't get me wrong. Like, we need to work on food quality and food accessibility and food affordability, and all those things are super important. But by themselves, they're just not going to change the equation enough.
Mm. Thank you so much. I'm just sitting and thinking of children coming to our clinics where everyone has been kind of hung up on the lifestyle modifications. So when the families come, the lifestyle, that's the message that keeps getting drummed into. I'll never forget one of the children I see in my epilepsy clinic. The mother saying, no, there's nothing we're doing that's different, but there's still lots of weight
Yeah.
gain and all that. So many.
So the data and people, all of my cutting edge, let's say, we'll use that because it's a nice euphemistic word for my out of the box thinking, but all of it is based in science. There's nothing unscientific about what I preach. And if you look at the data from the most intensive lifestyle programs that we have in the US, they're called intensive IHBLTs, intensive healthy behavior and lifestyle treatment programs. And they're supported by the Center for Disease Control in the United States and also by the American Academy of Pediatrics in the United States. And what those programs entail is 26 contact hours. So that's an hour a week, every other week, learning about diet and exercise and participating in diet and exercise programs. And at the end of all that, the patients get on average 5 to 7% total body weight loss. So if you do the math for a 300-pound or 150-kilo patient, times 15 kilos, half of that is 7.5 kilos. So anyway, it's a small fraction. I can do it easier with pounds. 300 pounds, 7% is 21 pounds. And so at the end of 26 weeks, that patient now weighs 279 pounds. Who is going to enroll in that kind of program? Who's going to put in that kind of effort for that little benefit? And yet it is actually still on the CDC website and the AAP websites as the primary recommendation for children with obesity. I mean, I wouldn't do that. I wouldn't put in 26 weeks and for children, obviously it's different, right? Not only is it the child an hour every other week, but it's the parent taking them to the visit.
Yeah.
So it's 2 hours out of the parent's time at least.
Yeah.
And it's really hard for a lot of families, especially families whose parents can't afford to take 2 hours out of their time every other week. Like it's expecting too much out of our parents and families and patients.
Yeah, we're already dealing with quite different things.
Yes, they've already got enough on their plate. So again, diet and exercise are super important, and I don't want to minimize that, and I don't want people to criticize me and say that I don't care about those things, because I do. They're important, but they're not enough. And frankly, a lot of those changes that are needed are easier after a medication is started or after surgery. And then again, I should mention in your patient population, some of the medications that we give to help children actually cause them to gain weight. So then asking them to do more work because of a medication that we gave them, that we did this to them. Again, it doesn't make a lot of sense to me, but sometimes,
absolutely,
sometimes I feel like I'm the only one shouting from the treetops or from the mountaintops about it. But that's what I'm here to do.
I think that's why we need to get the message across, because sometimes it can be quite traumatic for the children, years and years. Some of them have developed low self-esteem because of their looks and just being teased at school and all that. A lot of them have been stopped and preferred to be home educated. And
so the data from the US are somewhere between 40 to 70% of children with obesity have an associated mental health disorder at some point.
40 to 70%.
Yeah. And it depends, obviously, which study you're citing and the different, how you define it all. But I would imagine that if you ask them the simple question, have you been teased about your weight? The number would be about 100% or 99% or something else. And I think the take-home message for your listeners and for everybody is that obesity is a disease and not a lifestyle choice. And so you wouldn't tease a child or tease a parent or shame a family if their child had childhood cancer or had asthma or had whatever else. So we need to get over the tendency to blame and shame parents and their children for the disease of obesity. Like, it's not that simple. It's a disease. That same 40 to 70% is actually also the degree of obesity that's thought to be heritable or that you can inherit from your parents. I would say in children it's higher. It's probably a higher number, maybe as high as 80 to 90%. But again, I make the analogy that maybe a decade or two ago, we used to think alcoholism was a disease of weak willpower. And then when we learned that it was genetically driven, the entire field changed, and we understood that it was a disease that needed treatment. And obesity needs to get to that same point where we understand that it's not a person's fault. It's a disease that has genetic drivers. It has environmental drivers. It has societal drivers. We know lack of sleep and childhood trauma, adverse childhood events all lead to a higher risk of obesity. So it's multifactorial, but it's not due to willpower. That's the one thing we can agree upon. No parents chose to have a child with obesity. No child ever chose to be obese.
Yeah, that's right. I think what you have stressed for the audience is really important because you have, a lot of these families sometimes are so scared going into the doctor's office because the minute they tell the child to stand on the scales, the parents are petrified and they're anxious on almost like taking the weight, religiously and asking, how many pounds did they gain. That whole period of building up to that, they have been trying to do their best. And then it's not shifting on the weight. So it is something that we have to be very professionals as well. We need to be very careful because the kind of message that comes through during the consultation can affect them.
Yeah. So I'm writing a book on childhood obesity, which is part of the reason I'm out here doing podcasts and trying to spread the message. And in it, I relay a couple patient stories that would shock most MDs or providers and a lot of families as well. But the amount of stigma and bias that children with obesity face in the doctor's office it's crazy. I mean, we're supposed to be a place of healing and help, and we are actually stigmatizing our patients more. It's totally unacceptable, and it's our own fault for not doing a better job of educating our colleagues. But it's that probably makes me the most angry of all of it is when I hear about a doc or a provider who, stigmatizes their patients because of their weight. Like, that to me is just a lack of understanding about the disease and a lack of empathy, really. I don't know why we feel the need to judge anybody with any problem that they come to us for help with. So.
And Dr. Nadler, just going back for the purpose of our audience, could you talk a bit more about obesity itself as a disease and why it's a disease and what is obesity?
Seems like a simple question. But the reality is that in the adult world, especially right now, there's a lot of ongoing debate about how to define it. The Lancet Commission out of the UK put together all these experts to come up with a disease definition. And after like 5 years and all these meetings, they failed. They published their findings, but there was still no universal agreement on how to define the disease. So we use a calculation called the body mass index, which is a ratio of your weight to your height. And it's actually your height squared to be technical, but that's a screening tool. And it's a screening tool that was developed actually in the 19th century for nothing to do with medical use. And then in the 1970s in the US, it gained popularity as a way to define obesity. So currently we define it in the medical community as a BMI of 30 or more in adults. In children, we use percentiles for age and sex because the children are growing and the boys and the girls grow at different rates. But it's important to understand that it's just really a screening tool because certain populations, for instance, Southeast Asians, will have disease from or complications from their weight at a lower BMI than Caucasians, for instance. And the numbers that were originally used to make the BMI calculations, as no one is too surprised about, was based on white males. So it really is not necessarily applicable to lots of other populations. So it is how we define it right now, and it's the best we have, but it doesn't always correlate with health. So it is important to also understand how our weight is impacting a person. But their data actually from children, which are concerning, and it has led me to one of my new campaigns, which is trying to actually define pediatric obesity as its own entity. It's a different disease than adult obesity. But there are data that were published that show that adolescents with obesity, even if they have a metabolic problem at the time of the diagnosis, they are much more likely. They're 40 times more likely to have type 2 diabetes as a young adult than the average population. But even if you don't have a metabolic derangement at the time of diagnosis, you are still, I think, 20 times more likely to have diabetes than the average population. And you are definitely more likely to have a cardiovascular event as a young adult than the general population. So in children, at least, there are data that have been published that show that obesity-defined BMI, even what they termed in this paper as metabolically healthy obesity, which I don't really believe is the term, but even those who did not have a metabolic problem at the time of diagnosis were still at higher risk for having a cardiovascular event as a young adult. So the screening test is still pretty good in kids. And I would argue that the diagnosis of obesity, even by BMI alone, is often worth treating. So you shouldn't necessarily ignore it just because there is no obvious related complication at the time of diagnosis. And it doesn't get better.
Thank you.
You know, like in kids, 80% of toddlers with obesity go on to be adults with obesity, and 95% of teenagers with obesity go on to be adults with obesity.
There's
not really much benefit to delaying intervention.
Yeah. And you would think that for something that has a long-term risk, that we would be more aggressive to.
So that's another one of my soapbox issues, which is childhood obesity is actually more aggressive than adult onset obesity in terms of the complications and how quickly they progress. Yet we treat it less aggressively, which again is a dichotomy that doesn't make sense to me personally. And all these things, I'm just trying to change the way everybody thinks about this disease. And hopefully someday people will start to change the way they deal with patients.
Thank you, Evan. It's been really good having that explanation, because I think it's really good for our audience to understand obesity and understand what classes as obesity. And the hung up on BMI sometimes can get very rigid with people without actually looking at other aspects as well. So it's good to have that discussion. And with children with neurodiversity or differences, what happens why do you think they are more at risk? Because up to 1 in 3 children who are neurodiverse end up with being obese. So what's the cause? What does this get attributed to?
Well, certainly there could be a genetic component, and I've done a lot of genetic type work in my research days. But I also think sometimes when there are children with neurodiversity, it's really hard for parents, and they can only pick so many battles. And so let's say a child has a texture issue and will only eat French fries or chips, as they say in the UK. Then the family just will continue to feed that child those healthy foods. And it's not, again, I'm not blaming parents for that, but I do think there could be children they might have textural issues. There's talk about the beige diet where kids will only eat chicken tenders and other things that are beige. And those are not the healthiest options and can sometimes be difficult. And then on the flip side, exercise can be difficult because it can be hard to get children with neurodevelopmental differences adequate exercise. But that being said, I actually think it's in large part because the pediatricians taking care of them or the primary caregivers don't necessarily pay as much attention to that issue because they have the other issues that are going on. And so they might push the weight issue to the back burner until they get some of the behavioral issues better under control, which I understand as well. Although I would say you should try to take care of both at the same time because neither issue is going to get better without being addressed. So the kids who I would see initially with neurodevelopmental disorders who ended up coming to see me for surgical opinion were usually kids of parents who had issues themselves and maybe even had bariatric surgery themselves because they would sort of think about the obesity and behavioral issues. Like they knew that the obesity was going to cause a problem at some day. So they didn't want to wait for the behavior situation to be perfect before they came and saw me. And so again, I have lots of great success stories from children with neurodivergence, but not everybody's a success. And I'd be remiss if I said it was some magic bullet kind of thing. Definitely challenges. And the cohort that seemed to have the best success in my group were the boys with autism spectrum disorder, but in because sometimes if the behavior differences can be used to your advantage, for instance.
Yeah.
So, but like again, it's not all sunshine and roses or unicorns or whatever they say. I certainly don't advocate that every child with obesity get surgery or every child with neurodevelopmental differences and obesity get surgery. But I do think it should be offered to people and they should be able to get the information. Like I'm very much the paternalistic provider role. I think it's long past its usefulness. I think everybody needs to know all the information that you have about everything that's out there and then be helpful to make the best decision for them. And if we don't step in as providers or MDs to give that information, people are going to get it from the internet and it may or may not be accurate.
Yeah, exactly.
I'd rather give it to them myself and just give it to people straight and then just let them come to whatever decision they think is best for them.
Yeah. And you said one important thing. You said sometimes people are waiting for the behavior to get better before addressing the other things. And one of the things is that this is a reflection for me as a clinician as well. And I hope for other clinicians listening to this is that what you said is sometimes we are seeing the weight creeping, but because we are so focused on other things, we're really not tackling that at that time. We are looking at all the other things and waiting for that to be sorted, which we can't put a timeline on when on those
again,
other things we're waiting for.
Right. And I don't blame clinicians for doing it that way, especially here in the US where the amount of time we can spend with each patient is short. And a lot of clinicians try to address the most pressing issue first. I worked very closely with my child psychologists over the years as we would do my program in general, but especially with the kids with differences, neurological differences. And a lot of even, let's say, some of the eating disorder kids, binge eating disorder, or kids with suicidal ideation, we would have lots of discussions about like, okay, what's really the best timeline for these kids? Because yes, you need the binge eating disorder to be under control before you want to do anything else. But it doesn't need to necessarily be perfect. It can just be on its way to being, like you don't want to, doing things sequentially isn't always in the patient's best interest. And like with the suicidal ideation kids, so suicidal ideation for your listeners, it's basically wanting to commit suicide. And we would have discussions about these kids, like so it's a contraindication for surgery to have active suicidal thoughts to go into surgery. But when's the right time? Like, how long should you be after that before it's okay? Like, does that mean you should never get bariatric surgery? Or does that mean you have to wait a year, 6 months or whatever? Which there's no right answer to. But the psychologist and I decided that probably the best time was while they were still in treatment for their suicidal ideation, is then we would be assured that they had a mental health professional as part of their care. I use that thinking the same way I think about eating disorders or neurodevelopmental disorders or whatever, is that maybe the best time to intervene is while everybody's all involved in the care and not when they're quote unquote better, because that's when people aren't paying attention necessarily as much. So anyway, I'm not trying to say there's a perfect time or a perfect answer, but it's just mostly, I want it to be thought provoking so that providers out there who are listening might think, okay, maybe I should change how I'm dealing with this problem. Maybe I should try something slightly different because maybe it'll turn out to be a better approach. Again, I don't know, but I've always been one to be more willing to make an error of commission, trying something new, than to stick to something that I know that doesn't work. So
can you tell us at what point do you decide this young person or this child is suitable for bariatric surgery?
So the easy answer is that I don't decide. The family decides and the patient decides.
Okay.
But the more complicated answer, which is what you're sort of alluding to, is how do I as a surgeon approach the patient? And joking aside, it is really in large part driven by family acceptance of the idea. And you can imagine a lot of patients when they first come to my office, the kid is driving the bus. Like the kid found me online and is like, I want surgery. This guy has all this experience, has all these great outcomes, and I want to be like that. And the parents come in very skeptical. And then the opposite is also true. I have times where the parents really want their kid to get surgery, but the kid has no interest whatsoever because, the kid isn't there yet. So again, my approach is that I really just try to give people the information that's available. Before the GLP-1s were approved in children, the discussion was different because there really weren't a lot of good medications for children. Obesity. Now there's at least one in the US that's approved for children. So
which one is that?
That's semaglutide,
Okay.
or Wegovy is the brand name, but I like to use the generic name.
Yeah.
But that's the only one in the US that's approved of the
Mm-hmm.
GLP-1s. In the US, Qsymia, which is a combination of phentermine and topiramate, is also approved down to age 12, but most of the insurance companies don't cover it, so it's not an option often. So we actually break
Mm.
medications apart and prescribe them separately because as generics, they're actually affordable. But so to me, if your weight is impacting your mental or physical health, then it's worth addressing. And whether you address
Mm-hmm.
it with medication or surgery is obviously more nuanced, but if you have type 2 diabetes, probably surgery is going to be a better long-term solution. I sort of look at it sometimes opposite to other folks, but if you're struggling with your weight, the younger you are struggling with your weight, I also sometimes think that surgery is a better option because that means your genetic drive and your epigenetic drive is that much stronger. Like if you're 8 or 9 and you already have prediabetes, let's say, or acanthosis nigricans, which is a
So it's setting earlier.
yeah. If it's starting with, if you have that at 8 or 9, in my mind, that means your likelihood of having a healthy adulthood is even less. So, when you're ready, we should talk about surgery because you're most likely going to need both, to be honest. You're going to need medication and surgery. And so I
Mm.
also try to get that discussion out in front because I think for too long, people in the obesity world have sort of argued surgery versus
Mm.
medication. But the reality is that it's a lot of people are going to need medication, then surgery, or surgery, then medication, or medication, then surgery, and then more medication. I mean, it's a chronic disease. It doesn't get cured
Mm.
in many people. So again, I like to call myself an intervention agnostic, meaning I don't really have any, like, just because I'm a surgeon doesn't mean I want to operate on everybody. I
Mm.
want to operate on people who want it and need it and who will benefit from it. But I'm not looking to
Mm.
perform surgeries just because I enjoy it and I actually don't
Mm.
make any more money if I operate more or less. So that's not a consideration. It is a combination of things. And there are
Yeah.
criteria that are set forward by our insurance companies and the NHM. And those are, again, sort of starting criteria. But sometimes I think the family decision has a lot to do with it. I don't want to, again, it's not a cop out. Like, I'm not,
Yeah. I
I'm
think
not,
that's what I'm
not
getting from our
yeah.
discussion, that the family are taken into the decision making process about what pathway they want to follow
Yeah. And,
rather than letting.
right.
Yeah.
And in most disease processes, I think that's appropriate, right? We were talking about the IHBLTs or the lifestyle programs. If a family just cannot make that happen,
Yeah.
there's no point in prescribing it or recommending it.
I
So,
mean, even for me, it sounds like
yeah,
torture to
no.
do
And,
that for
and I
26.
mean, I often say that, yes, I should eat less and exercise more personally. Like I would be
Yeah.
healthier if I did that. Could I commit to an hour a week, every other week? Maybe.
Yeah.
But not always, not every week. And so it's a lot to ask of people. I think if people have tried medications and don't get enough weight loss, or tried diet and exercise and don't get
Mhm.
enough weight loss, or if they have a very severe comorbidity that like metabolic
Mm.
dysfunction associated steatohepatitis or MASH, then I would be more aggressive in my
Mm.
recommendations. Or if someone has severe obesity that runs in both sides of the family where the genetics are not working in the patient's favor, those might be times where I sort of push a little bit more. But,
Yeah.
no intervention works if the person doing the intervention or having the intervention performed on hasn't bought it,
Yeah.
right? So it's not going to work. Surgery's not going to work if the patient hasn't bought into it,
Yeah.
just like medications won't work if the patient's
Exactly.
so. So I
So
try
you
to
talked about having some success stories. Do you want to tell us what, apart from the physical part
yeah.
of, obviously they would lose some weight and feel better. Are there any striking
I,
success
I,
stories? I mean, you're doing
yeah,
your book, so I'm sure
yeah,
you've got a lot in your book.
yeah. And again, there are tons, and like obviously, I'm happy when my patients get healthier. But the most rewarding stories are the stories of the lives that are changed. One that comes to mind is a boy from my early days who was sort of a social outcast who, after losing weight, was able to join a sports team and have friends for the first time in his
Mm.
life. Stories of one of my female patients who actually was a cancer survivor and then underwent bariatric surgery. And after all that and getting better, she's gone on to medical school. to pay
Oh,
it forward.
wow.
I have lots of kids who participate in sort of lived experience advocacy groups for obesity, which also like I love it when the kids get back and like want. I used to actually have a peer mentoring program that I put together where a kid who'd had surgery, I would pair with a child who was maybe starting the process. So they had someone who'd been through it to help guide the new patient through that process. And,
Yeah.
large majority of my kids were willing to be part of that. I had a whole cohort of American football players who were actually like mentoring each other because they were all going through the same thing. And so those are the things that, I mean, I'm sure it's the same way for you. Like the patients who go on to help other patients, like that to me is the best. That's the ultimate win.
Yeah.
Like
Yeah.
anyone who pays it forward for me, like those are the stories that I love the most. When a kid loses 100 kilos and goes from being super unhealthy to being very healthy, that makes me feel good for sure. But the things that make me feel the best are when that same kid then goes and says, how can I help someone else get the same
Wow.
outcome I did? Or how can I help?
Must be very rewarding for you to see
I,
children's lives being transformed, literally.
when I first started doing this in the 2000, I guess like 8 or 9 era, there was an adult bariatric surgeon who was basically helping train me. He was from Australia. So I'm not going to try to mimic his accent, but he did say to me, he's like, listen, Nate, these patients are going to be your most grateful patients that you will ever see.
Wow.
And I said to him, I was like, I didn't say this to him, but I was thinking in my head, what is he talking about? I take care of babies with deadly diseases and I save children's lives and children who are shot and this and that. And I do all this stuff. What does this guy know? But he was right. These children who like get to experience their adolescence in a healthy,
Mm.
peer place are super grateful.
And
And
it's just
I'm grateful.
very rewarding because already they've got a lot to contend with when they're going through transition into adulthood and finding employment. And it will give them another lease of life and self-esteem
Yeah.
to actually be able to. So we actually underestimate all the things that it would be of benefit for them.
Yeah. And there are data that show that adults with obesity have lower earning potential. They get passed over for promotions.
Wow.
And actually, there are data from my kids. We did a study on executive functioning, and children after weight loss have better executive functioning and actually have structural changes in their brain than the children with obesity before weight loss. And so there are all these mental health and physical brain benefits that go into it that we totally underestimate.
Yeah.
And again, it to me, like this was an argument I used to have with the endocrinologist when I first started doing bariatric surgery on preteens, on 12-year-olds and 10-year-olds. They would obviously have concerns about it because when I was doing it, it really hadn't been done before. But I said to them, like, even in a mental health or physical health, either way, do you think it's healthier to go through adolescence and puberty with 50 kilos of extra weight on board? Or after a bariatric surgical procedure that might get rid of those 50 kilos.
Mm-hmm.
And they would say, well, what about vertical growth? I was like, I don't know, but I can't
Mm.
imagine that 50 kilos. Again, back then I didn't know. Now we know it doesn't impact vertical growth. But back then I'd say, I don't know, but I do
Mm.
know what'll happen if I don't do something, which is they might grow taller,
Mm.
but they're going to grow sicker. And I'd rather
Mm.
take a chance that they'll be a little bit shorter, but a lot healthier. And it turns out they're not any shorter. So that it was just a theoretical argument. But again, the point was like, it goes back to sort of my first do no harm,
Yeah.
flipping the script on that. I was like, I know what's going to happen if I don't do anything, and it's going to hurt this
Uh,
child. if I don't do
I
anything.
like the way you flip the script. I've taken that one from you today. I've taken
Yeah.
that one from you
So
today.
your listeners in the U.S. will know about New Jersey, which is where I'm from. Your listeners
Mm.
in the Europe may not know as much, but we in New Jersey are like fighters and we're like instigators. We're sort of like maybe your typical football hooligan, where we're combative a bit. So that's why I flip the scripts, because I try to take the
Yeah.
words that people say and I say,
Yeah.
okay, I'll take that.
It's
Let me show you what it means to me.
if it's the other way.
Yeah. So I'm not
Well,
necessarily not a pugilist. I'm not going to fight you that way, but I am going to fight you,
words
brain wise.
wise. Yeah. Oh, even it's been such a wonderful time just having this conversation with you. I'm definitely going to invite you back, because I think this is a really important topic, and I've been reflecting on our practice here in the UK, and I think this is something that people need to hear, because sometimes we get fixated on the weight part and the immediate, not thinking about the long term, the
Yeah.
metabolic aspect, the journey for that person,
Yeah. And
and
again,
what
I'm
we
not
could
trying to
do.
judge any clinician or any family
Yeah,
for dealing with the way they do. I'm just hoping to open a few
yeah,
minds to doing something
yeah,
slightly differently or approaching the problem
yeah.
slightly differently. So,
Yeah. So what's the message you have today for
yeah.
parents and then clinicians as well?
Well, again, the number one message, which I said before, but I say it over and over again, which is that obesity is a disease and not a lifestyle choice, and especially childhood obesity. There is no lifestyle choice piece of childhood obesity. So that needs to just go away completely. And the corollary, let's say, or the second bit of the tagline is that there's something you can do about it, right? You don't
Yes.
have to just do diet and exercise forever and ever and then have it fail and then get frustrated and not want to see doctors anymore. There are medications and surgery that have been shown to help, and they might not be right for everybody and may not be right for your listeners, but it might be right for some. And so it's more again about just opening minds and people knowing what options are out there, and then having parents and families hopefully find a clinician who can help them discuss those different options and the pros and cons in an empathetic and comprehensive way.
Where can people find you? Where can our guest find you?
Yeah, so I'm
And
actually not hard to find, and I actually am very responsive. In fact, probably too responsive to emails. So the easiest way to find me, if you really want to contact me directly, is my email, which is my first name dot my last name, and then at my initials, which are epnmd.com. But my website is called Obesity Explained. My YouTube channel is Obesity Explained. Instagram, Obesity Explained. They're all the same. Again, I'm just out here to help, and, hit me up. No worries. If we need to get more people in the UK
yeah,
interested in this problem, because there's some, and it's starting to take hold, but the childhood obesity epidemic it's in the UK,
yeah,
it's in India, it's in Asia,
yeah,
other Asian countries. It's making its way through the Middle East, actually. A lot of the
yeah.
Middle Eastern countries have
Yeah,
that.
it's in the Middle East now. We
Yeah.
definitely in the last few
Yeah.
years it's a problem. Yeah,
Yeah. So we need
definitely.
we need a little bit more global outreach. So I'm certainly happy to be on
Yeah,
this podcast and start that discussion outside of the
yeah,
US as it continues in the US.
yeah. Thank you. Thank you so much for spending your time with us. Thank you for all the information you've shared. We really appreciate it. And it's been an insightful session. I personally, I have taken on board quite a lot because, as you said, when we are seeing the children, we see sometimes we get very focused on the immediate concerns. And sometimes we're probably not tracking that weight and looking at things the way we should. So, again, it's a call to my fellow pediatricians out there and other clinicians that we need to be more responsive and be more proactive, looking at options and looking at what we're asking our children to do, and what challenges they're going through with the dietary and the
Yep.
lifestyle choice, and when do we review that, when do we look at other options. So thank you so much.
My pleasure.
It's been
And we still need to fight policymakers and the food industry
yes.
and all those other things at the same time. But yeah, we have a lot of work to do as a community.
Yeah. When is your book coming out?
I think it's probably going to be fall of 2027. I actually just signed my contract like a week or two ago, and
Okay.
now I have to write the rest of it, which is so I got to do that first. But it's coming. It's all up here. It just hasn't been typed out yet. I got to get that. That's
Let
on
us
my
know.
to-do for sure.
Yeah, let us know definitely. Yeah, we'll invite you back to talk about that. Thank you so much, and I hope you enjoy the rest of your time away.
My pleasure, and good luck. And thank you for doing what you do, because you take care of a lot of kids that need help. And then you're out
Yeah.
here on the social media trying to spread the good word. So thank you for that.
Oh, thank you. Thank you so much. Thank you. Yeah.